Hello, this is a meningitis grand round presentation. I'm Sandra Hurst, and many of you may know by now that I am a medical surgical orthopedic nurse. However, I have never taken care of a patient with meningitis. This presentation involves a fictitious patient and is based on knowledge and teaching of how to take care of a patient with meningitis. Learning objectives. Review etiology and pathophysiology of meningitis. Identify normal and abnormal neural and physical assessment findings. Perform research for best evidence of clinical practices for treating meningitis. Demonstrate use of critical thinking and clinical judgment for meningitis plan of care. And implement teaching and health promotion on meningitis prevention. This is the patient introduction. This is Mr. L.O. He's a fictitious patient, as mentioned earlier. His situation is that he's a 27-year-old Nigerian-born male who presented to the ER with worsening, unbearable headache. His history of present illness is that he had a severe, continuous, worsening, throbbing headache with a stiff neck that began 5 days ago, with unrelieved pain at rest that radiates to the posterior neck and is aggravated with activity. His social history is that he liked to play sports, he loves concerts, he's a college student, a non-smoker, he drinks beer on weekends, he works at a gas station, and is single. His past medical history is asthma, seasonal allergies, constipation, lactose intolerance, mild vitiligo, and oligospermia. His family history is that his mother has generalized vitiligo. She has depression. His father has ETOH abuse with 16 ounces of vodka daily. His sister has ovarian cysts, and his family history is negative for CAD and diabetes. The patient take medications, which is Zyrtec 10 milligrams daily, Tylenol 650 milligrams Q4 hours as needed, and also he takes Metamucil for his constipation as needed, and Albuterol as needed for his asthma. The patient has no known drug or food allergies. The review of systems. The tegumentary. The patient reported mild vitiligo that is concentrated in his anterior and posterior chest. He also reported a pruritic rash, and he reported skin tenderness in the outer canthus, the outer left canthus, from constant rubbing to relieve the headache. In the EENT and neck area, he denies hearing, vision, smell, or taste loss. Also, he denies sore throat, dysphagia, or oropharyngeal abnormalities. And he reported stiff neck with increased pain while bending the neck forward. His neurological system is that he was alert on at times 3 with periods of confusion. His central nervous system and cranial nerves 1 through 12 were normal. The patient stated, "The worst headache in my life, and very seldom have headaches." And the patient reported dizziness and tiredness. In his gastrointestinal system, he reported decreased appetite and reported nausea and vomiting. And the last system that was reviewed were the cardiovascular and the respiratory. The patient reported a racing heart and rapid breathing. However, he denies chest pain or shortness of breath, and he denies breathing problems. This is the patient's physical examination. His vital signs, height and weight were taken. His blood pressure was 145/83, heart rate 110, temperature 99.8, respiration 23, and saturation O2 96%. His height was 142 centimeters. His weight was 76 kilograms, and his BMI was 21. During his integumentary examination, his skin turgor was normal. He had that generalized macular rash. His color and mucous membranes were normal for ethnicity. He also had mild vitiligo on the posterior and anterior chest, as he reported earlier. During his musculoskeletal examination, he had no limited mobility except for the stiff neck. And as we learned in nursing school, he had a positive Kernick's sign, which means that when you have the patient in a supine position, you would lift his leg up and it will elicit pain. And the Brzezinski signs would be when you lift the patient's neck passively, all of a sudden he would have an involuntary movement in his leg. It would kind of suddenly jerk upward. And also the patient had weakness and shivering with cold hands and feet. And the patient appeared weak and tired. In his neurological examination, his pupils were equal, round, and reactive to light and accommodation. The National Institute of Health Stroke scale was negative for CVA, which is cerebral vascular accident. And his last examination was the gastrointestinal, which he had hypoactive bowel sounds, no rebound tenderness, and his abdomen was soft and symmetrical. The risk factors for meningitis would be children, people with immune incompetency, being in large crowds, and cigarette smoke. Also, being a college student, surgical procedures, and lab microbiologists who work with meningitis bacteria regents in the lab, and traveling to the African sub-Saharan areas. The etiology of meningitis is enterovirus at 50.9%, bacterial meningitis at 14%, and unknown etiologies is at 18.7%, and the herpes simplex virus and herpes zoster can also cause meningitis. Also, age, which is infants, who are more prone to catch group B streptococci meningitis and gram-negative or Listeria monocytogenes meningitis. And young adults usually are more susceptible to Neisseria meningitis and Streptococcus pneumoniae. Also, older adults usually are prone to to this bacteria as well. However, Streptococcus aureus occurs in all age groups. And also the other etiology is immune incompetency and the route of pathogen entry. Meningitis Pathophysiology. It is began by droplets or saliva transmission. It is then facilitated by bacterial adhesions, internalins, pili, and pore-forming toxins that cross the blood-brain barrier. The pili of the bacteria are hair-like projections that assist the bacteria to penetrate this barrier. And once it's penetrated, then the bacteria enter the subarachnoid space, where rapid replication of pathogens begin. Minute white blood cells in the cerebrospinal fluid initially causes no inflammation. However, the bacteria that are in the CSF consumes glucose. Protein and glucose levels are changed in the CSF. Protein levels increase while the glucose levels decrease because the bacteria need the glucose for the energy. And bacteria produces protein in order to assist in the replication process. Then bacteria later releases toxins that causes inflammation that is triggered by the WBC's mediators. The pathophysiology of meningitis continued. Due to the white blood cells mediators, they cause cytotoxic edema that increases intracranial pressure, that triggers plasma cell immunoglobulin production, and the influx of leukocytes produced in the cerebrospinal fluid, which causes a further inflammation in the subarachnoid space that results in cortical encephalitis and ventriculitis. Arterial / venous thrombosis are formed due to the inflammation and causes infarct of brain tissue. The cranial nerves 6 and 8 are affected, that causes abducens palsy and deafness. Then infection penetrates the brain parenchyma. And finally, cerebral herniation can form, which is the most common cause of death. And as you can see here in this photo, this is just one example of a bacterial pili as shown as the projections. This is the microscopic view of viral meningitis. As you can see here, on the top right of your screen are the normal meninges, and right below that is meningitis. And to the left side of your screen are the location of the meninges and the brain tissue. Clinical and diagnostic manifestations. After the patient has spent about a couple of hours or more in the emergency department, he continues to experience a headache, nuchal rigidity, which is the stiff neck, and now he has a fever that went from 99.8 to 101.8. He continues to have the rash and an altered mental status. And he states to you that he doesn't know where he's at and he feels like his mind is in the clouds. He had a CT of the head that was done that showed a positive intracranial pressure, cerebral edema, and edema of the meninges. But it was negative for cerebral herniation and cerebral shift, which would have showed a Glasgow Coma score scale less than 12, with focal neurological signs. The patient also had not experienced any type of seizures. However, other tests had came back positive, which was the immunochromatographic antigen test, the polymerase chain reaction, and the latex agglutination that was positive for bacteria. Also, he had cerebral spinal fluid cell studies that were positive that will be explained later into this presentation. And also he had cerebral spinal fluid and serum blood cultures that were done and positive for bacteria. So now that his fever had increased and now he has an altered mental status, what do we need to do about this? Well, first you want to cool the patient down immediately to prevent further cerebral damage. You want to give him some Tylenol and plus put some ice packs on it. And then you need to further assess him for his altered mental status, which you would review the CT results. This is a guide for the normal CSF diagnostic interpretations. The normal CSF, which is the cerebral spinal fluid, for open pressure once the lumbar puncture has been done will be less or right at 20. And for the white blood cell count, it would be 0 to 5 for lymphocytes. And for the CSF protein, it would be 0.15 to 0.45. And for the CSF blood glucose ratio, it would be 0.6. And for bacterial meningitis, it would be greater than 20 for the open pressure. And for the WBCs, it would be greater or right at 1,000 for the neutrophil count. And for the CSF protein, it would be at or greater than 1. And for the CSF glucose blood ratio, it would be less than 0.5. And for viral meningitis, the open pressure is the same, and the WBCs would be less than 1,000 for the lymphocytes. And for the CSF protein for viral meningitis will be less than 1, and it would be the same for the CSF glucose blood ratio, which would be normal. For the CSF glucose level at or less than 18, or for the CSF glucose ratio of 23% or less, it is a strong possibility of bacterial meningitis. However, changes in CSF glucose may be delayed for half an hour to 2 hours, and changes of blood glucose. In acute bacterial meningitis, an increased protein level of 100 to 500 indicates blood-brain barrier penetration. This is the patient's lumbar puncture and imaging results. The normal CSF glucose is 50% of the serum glucose. His CSF open pressure was 31. His WBCs was 15 for the lymphocytes. And the CSF protein was 5. And the CSF glucose blood ratio was 19%. For the bacterial meningitis, his open pressure was 46, and the WBCs was 1250 for the neutrophils, and the CSF protein for the neutrophils was 200.5, and the CSF glucose blood ratio was 2.0. And for the viral meningitis, the open pressure was 6. And for the WBCs, it was 1.2 for the lymphocytes. And for the CSF protein, it was 0.02. And for the CSF glucose blood ratio, for the viral meningitis, was 0.5. The patient's CSF glucose level total was 11. And the CSF blood glucose ratio was 19% as stated, and that highly suggested for bacterial meningitis. And his blood culture and CSF cultures were positive for Streptococcus pneumoniae. And as stated, his CT results was positive for intracranial pressure, inflamed meninges, and cerebral edema. And now to the right side of your screen, these are the blood chemistry interpretations after the patient had lab work that was done and his lumbar and puncture was completed after the CSF studies. And as you can see on the lower screen, his white blood cell count has increased. And again, this is for the blood chemistry, and that's why his blood culture was positive. Once you have completed your initial assessment, you will begin the meningitis treatment plan. You will use droplet precautions. You will urgently address airway or circulatory compromise. You will draw blood, including blood cultures. Then you will follow the algorithm from there. Okay, after the patient has spent about 4 to 5 hours in the ER, you went to recheck the patient and his vital signs. You retook his temperature, and it was 98.9, as it had went down from 101.8 after you gave him Tylenol and cooled the patient down with ice packs. However, you found the patient to be semi-comatose with irregular respiration. And you took his blood pressure, and it was 198 over 111, and his heart rate was 47. And the patient was supine. So what are you going to do at this point before you even call the doctor? Okay, you're going to immediately elevate his head greater than 30 degrees. You're going to maintain the patient's neck at midline to promote venous drainage from the head. You're going to hyperventilate the patient to reduce pressure CO2 to 30 to prevent hypercarbia that increases ICP. And then you're going to give the patient mannitol after you speak with the doctor and you're going to give it to him as an osmotic to reduce cerebral edema at doses at 0.25 to 1 kilogram per body weight, as you weighed the patient earlier in the examination. Or you can give the patient 3% IV normal saline bolus or continuous fluid. And after you had called the doctor, he had ordered a CT of the head, and it was positive for pending brain herniation. After you had implemented all these interventions and that was ineffective, okay, you're going to call the doctor again, and he's going to order for the patient to have surgery, which he may have possible craniectomy to reduce the brain progressing herniation. The craniectomy will allow the brain to swell without herniation and poor outcomes. After the patient had his surgery for about 2 or 3 hours, you rechecked his vital signs, and his blood pressure had decreased to 134/66, and his heart rate had increased to 68. And these are the clinical and diagnostic manifestation of increased ICP after the CT was done and after the patient had explained many of the symptoms of that he was experiencing. For pharmacologic therapy, prompt treatment within 1 hour of admission is crucial. You would give the patient dexamethasone, 10 milligrams every 6 hours for 4 days. For pneumococcal meningitis, this medication decreases edema and ICP. For the patient's diagnosis, which was Streptococcus pneumoniae, vancomycin would be given, which is more effective against these bacteria. And if the patient had a virus meningitis, you would prescribe him with acyclovir for improved outcomes. If the patient had the Listeria monocytogenes meningitis, you would give him the benzopenicillin and the trimethoprim sulfamethoxazole. For non-pharmacologic therapy, you would initiate droplet precautions for the first 24 hours of antibiotic treatment. You would then make a prompt consult to the infectious disease doctor. Then you would get an order for a CT of the head and a lumbar puncture. Then you would need to know viral meningitis is self-limiting, and supportive treatment is the only thing that's needed. You would elevate the head of bed at 30 degrees to decrease ICP. And then you would hyperventilate for pressure CO2 to 27 to 30 to promote cerebral vasoconstriction. Health promotion and teaching. You would teach the patient to get a meningitis vaccination depending on his or her age. And the patient would need to speak with a doctor according to the type of vaccination is needed, because there are more than one meningitis bacterial vaccination. Also, you would teach the patient, if he or she has been exposed to meningitis, that they would need to seek a prophylactic treatment, because this treatment needs to be done as soon as possible, because if meningitis treatment is delayed, it could be fatal within days, especially specifically for bacterial meningitis. And also, you would provide the patient with reliable information for understanding types of meningitis bacteria, because certain bacteria need a certain type of treatment. And for the health promotion, you would tell the patient to avoid cigarette smoke and secondhand smoking, and get adequate sleep. Avoid close contact with ill people. Wash hands, cover cough, and avoid sharing utensils and other items to prevent meningitis. Patient outcome. The patient had a partial craniectomy and was sent to the post-anesthesia care unit and was monitored there for about 2 to 3 hours. And then he transferred to the neuro ICU. Radiologic and diagnostic lab tests were continued to be performed. The patient's cognition had improved and was alert times 3. His vital signs were taken. His blood pressure was 129/78. His heart rate was 72. Respirations were 16 and regular, and his temperature was 98.4. After 4 days in the ICU, the patient was downgraded to a progressive care unit where he had neurologic checks every 2 hours. And then the patient continued to have pharmacologic and non-pharmacologic treatments with improvement. With improved stability and cognition, the patient was downgraded to a medical floor. And then the patient was given post-operative and other discharge instructions after a total of 9 days of hospitalization. Conclusion. The patient presented to the ER with unbearable worsening headache and a stiff neck. The diagnostic tests were performed. The patient was diagnosed with Streptococcus pneumoniae meningitis. Immediate treatment was initiated with medications and supportive care. There were periods of patient deterioration and improvement despite immediate treatment. Symptoms of ICP had improved with immediate supportive care. The patient had continued pharmacological therapy and was discharged with continued home care. And now, after you have reviewed this presentation, what is the most important thing that healthcare providers need to discuss with this patient? Remember, the patient had presented to you, to the ER, experiencing a worsening headache with a stiff neck for the past 5 days. So what is the clue that you need to teach this patient? And I welcome you to include your answers in the discussion board. And this will end the presentation. And thank you for listening. And I welcome your questions, comments, and suggestions.